Hello, everybody, and welcome to our session on Governance for Healthcare Transformation, Harnessing the Power of Laboratories. My name is Colleen Strain, and I will be your moderator for this session. Today's session will last approximately 75 minutes. So today we have the pleasure of discussing how laboratories have the potential to favorably impact decision-making and clinical governance as powerful collaborators and catalysts of value to health systems. This is vitally important as laboratories can contribute well beyond medical diagnosis and therapy and provide insights that guide the development of precision and personalized medicine, prompt the shift towards prevention, and are protagonists for innovation and transformation. With us today are three esteemed speakers who will highlight the need for new governance models that acknowledge the benefits of involving multidisciplinary stakeholders, including laboratory medicine, in organizational decision-making to successfully address complex healthcare challenges and drive healthcare transformation. Let me introduce our wonderful speakers and panelists today. With us here is Professor Federico Lega, who is a professor in healthcare management at the Department of Biomedical Sciences for Health at the University of Milan in Italy. Professor Lega is one of the experts involved in the assessment committee of care projects submitted to the Univance of Healthcare Excellence Award program, and the leader of initiatives to document and highlight the value of laboratory medicine and recent transformations and expectations for innovations susceptible to impact care delivery and health management. With us as well is Dr. Ellie Dow. Dr. Dow is a consultant in biochemical medicine and a consultant in charge of all biochemistry laboratories in the NHS Tayside University Hospital Trust. Ellie has a particular interest in clinical diabetes and regularly holds the clinic at the Diabetes Center at Ninewells Hospital. Her research interests relate to genetic markers of risk prediction, and she has an active interest in defining the genetic predictors of complications in people with diabetes. Lastly, Professor John Dillon is here with us as well. He is a professor of hepatology and gastroenterology and a principal investigator in the Division of Molecular and Clinical Medicine at the School of Medicine at the University of Dundee, which is based in Ninewells Hospital. He is also an honorary consultant with NHS Tayside, leading a busy general hepatology service and research group. He's also the Vice President for Hepatology of the British Society of Gastroenterology and is a past president of the Scottish Society of Gastroenterology. Welcome to all our wonderful speakers. Now, before we get into our discussion today, I do have a few brief housekeeping items. We welcome and encourage you to put forth any questions or comments you have throughout the panel discussion. You notice on the right of your screen, there is an option to include comments and questions, so please feel free to do so. We have a dedicated session at the end of our panel where we will address all the wonderful questions you have. So without further ado, I will pass this over to Professor Lega, who will kick us off with the discussion, presenting his views about the need for governance models that include multidisciplinary stakeholders. Professor Lega?
Thank you, Colleen, and good afternoon, everyone. I'm very happy to be here today in this specific session. As Colleen was saying, I'm very fond of the role and contribution that laboratories and laboratory medicine is giving and can give to the future health system. So what I'm going to do now is use this 10 minutes I have to share with you my views about why we should actually do much more in order to value and recognize the contribution that the labs can give to modern health medicine and specifically to the development of the type of innovations and reconfiguration we want to see in health service delivery. I'm going to load my slides quickly. Okay, now you should see them. So the starting point of my introduction, to understand my positioning of the rest of the conversation we're going to have with my estimate colleagues is the following one. So I do believe the laboratories should be considered key drivers in developing what we can label or name effective health service delivery within the new normality of healthcare. Now, we could do a long conversation about what we mean by new normality, but I will try just to summarize the two major paths we were trying to pursue in this specific period of time and in the recent years, along the two points that you see on the bottom of the slides. One is developing what we call population health management. So what we try to do in the health system is try to be very much proactive towards the way we manage health of a population. We try to anticipate. We don't want the system to be reactive. That means actually that everything that has to do with preventive medicine, with preventions, with mapping is becoming more and more important. So to some extent, we have a completely new discourse coming to health system, which is less focused on curing and caring patients, is more about nurturing citizens, becoming their own responsible for managing their own health, but also to be more active in searching for prevention, procedures, medicine, and a number of other things that I'm going to show you are very, very well connected with laboratories. So in moving the health system from being reactive to proactive, medicine, laboratory medicine and laboratories certainly are key drivers in this. I mean, we need the examinations, we need the tests, we need that area as becoming really focus of investment in the health system. And second major path can be summarized around the idea of value-based healthcare. So there's a number of things connected to value-based healthcare. It goes from value-based procurement to value-based service delivery to multidisciplinarity to integrated practice units. I mean, most of you probably are very familiar with the paradigm of value-based healthcare has been introduced 10 years ago by Michael Porter's research team, but then has developed in many different ways. What I just want to underline here is within the value-based healthcare, it becomes of paramount importance to focus a system on outcomes. And if we want to improve outcomes within the health service delivery system, then laboratory and laboratory medicine becomes so fundamental in supporting and in coaching, sometimes in tutoring the way clinicians are performing their work as diagnosis and then the way they decide about therapy. So again, value-based care requires a step in and is based in many cases on the work done by laboratories. So this is what I'm going to show in a moment. But what is the issue then? We do have an issue right there, because if I look actually my personal experience as consultants within health organization and system and my almost 10 years experience with laboratories and laboratory medicine, what I often felt is the fact that top management doesn't know much about actually what's going on in two labs, their daily operations, and they don't perceive that the value of these operations. So they're very disconnected often within a hospital or health organization from the laboratory. Laboratory is often perceived as sort of a commodity, not really. Is often not even considered like central, like a clinical activity or like a clinical unit. This is not the same reputation, not the same status. And worse, actually, most of the time, top management see the laboratory as a driver for high investments, cost, high expenses, whether it's because of the upfront cost of the technology or whether it's because the cost of the daily activity. But most of the time, what we see is that, this is really my experience, but it's been obviously reported by research. There's a mixed conception about labs medicine and laboratories. The implications, the fact that labs are often perceived as cost centers rather than value generating unit for their health organization, for the health system they work for. So any action to reduce their costs is more than welcome often by health system and by health organization. We've seen a lot of concentration attrition, a lot of research for outsourcing, downsizing over the last years. And often this actually has been also accelerated because constraining the cost of laboratory is easier than constraining or reducing the cost of other clinical units, which are more sensitive from public opinion or for the type of work they do in terms of acute. But obviously this is just a big misconception, because at the end of the day, if you constrain the laboratories, you are also constraining the clinical activities done by the clinician. So it doesn't really make sense. But that's what happened. And even strategies, as I've put in this slide, even strategies could actually improve labs work, like searching for creating networks, hub and spokes within labs, has been often instrumentalized or used with instrumental scopes, which could be reduce costs rather than actually improve capacity and capabilities and generating a more effective network. So there's quite a cultural shift that needs to be done within the system. And I think actually the work done through the Uniwans Awards promoted by Airport and by all the activity, and even this session, are very, very, very welcome in that direction, because there's clearly a need for that. Once we recognize that laboratories could be really good benchmark for the health organization, for health system, in actions and practices to improve system and safety standards, to achieve multidisciplinary, multi-professional teams, to focus on clinical or appropriate care, because labs has been exposed before than other clinical activities to that kind of pressure to become safer, to become more integrated in the work between physician and technicians, to be more appropriate in the way tests are delivered, in leading research on innovative areas and connecting this research to the production of outcomes, in adopting new delivery models from both the technical and pathway viewpoints, if you look at the patient journey through the labs, and generating clinical governance. So there are many issues in which the labs, many areas in which labs could really be a benchmark for the health organization, where there could be lessons learned from the labs, and where we should value what has been doing in the labs over the last 15, 20 years in many systems. And at the end of the day, they really are big players in the quest for the two big things actually that we have in the health policy agenda: improving outcomes on one side, and I think in the rest of the conversation, our colleagues actually will show us how lab medicine is fundamentally connected to the delivery of best outcomes for patients. Without good lab medicine, there's not really chance that we get the best outcomes for patients. And secondly, it's key in moving the system towards what we called before predictive medicine and precision and personalized. So it's really at the core of the two major changes that should actually affect health policy in our system over the next years, and really make us put us in the condition to do the leap towards the next level in the performance of health system and health organization. So at the end of the day, and this is the points that I really want to stress in my introduction, and I'm sure I'm going to see confirmation in the rest of the discussion today. We want labs more and more involved in system governance and policy making. What I mean by this is that the lab physicians should sit at the tables, should sit in the committee where decisions about how to change health policy is being doing, because they are key in generating predictive medicine, in generating precision medicines, in generating population health management, or the precondition for doing population health management. So they should sit on the governance table, they should sit in the policy making level, not just as often happen to other clinicians, which are more recognized, more how to say that they have more reputation status within the system, but lab physician, more than others, actually should be sitting at those table. They should basically involve very much in clinical teams delivering pathways. Most health organizations are generating transversal lines, multidisciplinary teams, centers, whatever you want to call them, clinical service lines. So I want the lab physicians to be part of the multidisciplinary team, leading clinical decision making within the teams. And then they should be very much involved in the clinical governance strategies of their health organization, because they can do really a massive work in educating their colleagues sometimes in the way they use tests, examinations, how to proceed in the right pathway for generating diagnosis, how to use innovative technologies, and so on. So the three major reason for which I want to see the lab physicians and laboratories more involved in the decision-making process at all levels in the system. And then we need health system and organization to recognize value and contribution the labs generate for them. So the other things, actually, I think we need all together to make the system and the health organization more sensitive about the fact that the lab medicine is not a cost, but it's an investment. It's generating a payback, exceptional payback when it comes to look at how actually could support and accelerate the type of changes that we want to see in health service delivery on one side, focus on outcomes, and in health system policy when it comes to managing the population. Colleen, I'll stop here. This is the things that I hopefully will set the ground for the rest of the conversation. The floor is back to you, and I hope actually I was clear enough in stating my messages.
Absolutely. Thank you, Professor Lega. And you were absolutely clear and spot on. I really appreciate the points that you highlight here about so much of the opportunity as well as some of the problems that we see in really starting to highlight the value of the laboratory. And I know you mentioned the Univants of Healthcare Excellence Awards and why that's a great vessel for starting to highlight the value that collaboration with laboratory colleagues can really highlight that aspect. And so I think that's a really wonderful point, and in part why we have our two other wonderful panelists here. As the Univants of Healthcare Excellence Award program looks to recognize integrated clinical care teams who have unified across the care continuum with laboratory, clinicians, IT, and beyond, really to achieve something measurable and make a difference within a healthcare system. And so our two panelists, Dr. Ellie Dow and Dr. John Dillon here, were actually recognized in 2019 for their fantastic and innovative intelligent liver function testing algorithm. And they've seen some of these benefits that you mentioned related to, shifting towards that integrated model with the laboratory and being less of a cost center versus generating the value. So Dr. Dillon, Dr. Dow, welcome again. And I'm looking forward to hearing a little bit more of your perspective on some of the items that Professor Lega has presented on. So if you won't mind, can you tell us a little bit more about your ILFT or intelligent liver function testing algorithm, as well as the team that was involved and the decision-making process around the initiative itself? John, I think you're still on mute.
We'd be happy to do that. I'm going to share a couple of slides and Ellie and I will move between them. If you can see them. So this first, it's moving to. So this first slide looks at the rate, the age standardized mortality for different diseases in the UK from 1970 as a standard to 2010. You can see liver disease has gone up and up over that time. And if you look at liver disease in more detail, 3/4 of those patients are under the age of 65, and most of them are presenting for the first time with decompensated liver disease, which is a very expensive business, very dramatic presentation with a high first presentation mortality. But if you look back through those patients' histories, many of them will have had contact with services and have had liver function tests measured within the lab that haven't been appropriately acted upon by the clinicians. And so the idea of ILFT was to try and automate that early interaction and feed back to the clinicians what they should be doing with the tests and give them additional information, and often do the first stages of the tests that clinicians would do in the subsequent referral pathway. So as Federico has already alluded to, making the labs, improving the quality of care, improving the governance around the use of those results, but also aiding and supporting the clinicians in making better decisions. And so what does ILFT look like in the real world? We can move on to the next slide. It's not... I'm having a slight technical problem moving my slides on. Hopefully you can see that now. So in ILFT, what happens is the general practitioner requests liver function tests as bilirubin, alanine transaminase, gamma GT, and ALT-FOS. And when the blood goes to the lab, if those lab results are normal, then the results are referred back to the GP in the usual way as they're requested. But if the results are abnormal, then there's a series of reflex testing within the labs, and some clinical details that the general practitioner has been asked to supply around alcohol consumption, the BMI, and the presence of the metabolic syndrome are integrated together into the lab to give real-time reports back to the GP, and there are potentially 32 outcomes. I think Dr. Dow is going to talk to us about what happened in the lab and how they've manipulated the systems to allow that to happen.
Yes, thank you, John. It's probably worth saying that this came about because John and I had a corridor conversation. John and I have known one another for many years, and he knew that we'd been lucky enough to have substantial investment in laboratory systems in NHS Tayside, both at an IT level and within the lab. And certainly at the time we had this initial conversation, we were probably the most advanced lab in an automation point of view, certainly in the UK, and we were a world demonstrator for the systems that we had. Harking back to what Federico has said, yes, we had a lot of investment, but that investment was because we had been looked on as a cost centre, and the investment allowed the institution to save an awful lot of money over a large number of years, rather than the institution actually thinking what wonderful things that we might do with this new equipment. It was a cost-saving exercise. So we had this conversation, and essentially we formed what we would call now, although we didn't in those days, a co-production team. So we had clinicians and experts like John, we had general practitioners, we had most of the laboratory specialties represented. So myself from chemistry, I led the overall lab side of the project, hematology, virology, immunology, and we had a vision really about how this might work, using the knowledge that we gained about how these new systems came into play. So the vision really was that it should be very, very easy for general practitioners to request an intelligent liver function test. It should be as easy as requesting a normal liver function test. So it should be a tick box. And it should be easy for the information that we required to make the whole algorithm work come over into the lab. And really, all that happens in the lab should appear almost to be really like a black box to them. That complexity, all that IT programming that we had to do, all of the problem solving that we had to do to get over the problems of working with old IT systems, and the fact that traditionally laboratories have been individual silos. So we managed to get by all that, but all of that complexity would be hidden to them, and that then they would get a result that would actually be a meaningful report, not just telling them about the implications of the result that they saw in front of them, but also giving them a management plan to move forward and what the next step for the patient should be. So that encapsulates probably about 3 years' work in a couple of minutes. John and I had many corridor conversations where he would say, how's it going? And I would say, this isn't working, that's working. But eventually we got through it, and we managed to deliver an intelligent liver function testing program that's delivered to the GPs and to John as a hepatologist, a service that is very, very different from what we had before. The benefits for the lab are really immeasurable, because we have much, much closer contacts with our clinical colleagues. We've gained recognition within the local health economy about the quality of our work, and some subtle changes that are now really much more tangible that we hadn't really anticipated. So we came together more as laboratory specialties, and now we've actually coalesced blood sciences, immunology, and microbiology into a single management unit, because we realized we actually were far better working much more closely together. So that's a very big change it encouraged actually within the laboratory services. I don't know if there's anything else you would want to add, John, now about the outcomes from ILFT.
I think we have the measured outcomes and the modelled outcomes. So this started as a clinical trial with NHS Tayside and is now across the whole of Tayside's routine service. But it increased, it over doubled the rate of new liver diagnoses. So dramatically increased our chances of finding those patients before they presented to my emergency room with decompensated liver disease, and so allowed us to institute care earlier. And if we know if you make a diagnosis of cirrhosis in someone before they decompensate, they have a median life expectancy of 12 years after that event. If you make the diagnosis at the time of decompensation, their median life expectancy is only 24 months. And so we've clearly had that patient benefit. From the measured modelling work, we see an increase in quality of life, which is small, but because it's across a large number of patients. But the small number of patients with serious liver disease, this is a dramatic change, that 22 months to 12 years, which is dramatic. There is a small additional incremental cost at the start, because lots of patients who were previously not being appropriately investigated are now getting proper state-of-the-art investigation. So while it appears as an increased cost, this is just the health service doing what its own guidelines say it should be doing, but it wasn't doing previously. And over the lifetime of the patient, each patient in the system accrues a £3,200 cost avoidance over time because of the interventions that we can put into those patients who have significant liver disease, which would be very expensive if it was to decompensate in the future. So these are the benefits that we have seen in the real world and in the clinical trials. And so this is a good example of what can be done about liver disease, but other complex diseases to diagnose, or some easier diseases to diagnose, where earlier diagnosis will make significant impacts, as Frederico was alluding to. It's working with the laboratories that allows you to achieve these outcomes and points of view. So I think that's enough of the slides, and Colleen, we can give it back to you and the floor.
Thank you, and thank you both for that wonderful explanation of your intelligent liver function testing algorithm, which is clearly brilliant. We've seen a few of the wonderful outcomes really from a patient and cost perspective. As we think about some of the points that Federico made, the laboratory being viewed as a cost center, and really how we need to shift to that value-based healthcare, and having them at the decision-making table so that you can use those colleagues and that information and insights that they have to drive change within their health system. Thinking about those points, Ellie and John, can you speak to any other impacts that you've seen in the hospital, whether it's clinical process changes, management changes, administration, etc.? Ellie, I know you spoke to even just the changes within the laboratory that you've seen, you're even more integrated. So have you seen any similar changes from a broader institution perspective as well?
I think after ILFT became more well known, we began to find that we were getting better representation in some of the intermediate and higher level committees within the hospital. So that process had already started. And I think the clinicians were very keen for people to be involved. Where there was maybe not reluctance, but perhaps less recognition of the need to have the laboratory involved was in the hospital management cohort, not the clinical management, but the management level. But I think that they've slowly learned their lesson, and the lesson has been accelerated really because of COVID. That has been a huge positive in a way for getting laboratories much more integrated into management processes within the hospital, because they have seen the power of laboratory diagnostics for managing major issues, not just the sort of chronic long-term, chronic conditions like we're talking about with liver disease, but also with the acute challenges that we faced. And I think one of the other things that actually also had an impact before COVID, a couple of years ago, we had a major incident in the hospital where a lightning strike elsewhere in Scotland completely knocked out most of our region. Basically, we lost all power within the hospital momentarily, but we lost power completely in the lab block. We lost all IT. We lost all hospital intranet across the region. We lost all telephony. And I think they realized pretty quickly, unless we get things back up and running, my lab basically had become a black box. I was using the torch on my camera, the torch on my phone to navigate around. They're going to have to shut the hospital to acute admissions because we can't do anything for anybody. So, losing things is one way to focus attention, and then realizing the huge response that the laboratory can put in for a very acute situation like COVID has actually totally changed the way the labs are looked at now.
Colleen, if I could come in again potentially around the COVID side of things, I think what ILFT illustrated is the ability to make a diagnosis effectively and quickly without necessarily the usual process of multiple visits to a clinician, multiple sequential tests. Here we were able to make firm diagnoses for a majority of patients based on sensible algorithms and simple results, which then meant that a large number of patients didn't need to come to hospital, didn't need to be seen in healthcare systems. And that shifted, we were still maintaining the quality of diagnosis, but moving a lot of patients out. And that's become even more acute with COVID, where we don't want significant numbers of people who are ill and slightly unwell coming into environments where they could then be exposed to other infectious agents, etc. So I think applying those principles more widely is illustrated what can be achieved with ILFT, where we've moved 70% of the patients that would previously have been referred back into primary care without the need for referral. We have increased the number of referrals that we should be seeing, and that's filled the gaps in hospital. But these are the patients with advanced disease that we can make the biggest impact from and use our resources most effectively.
That's fantastic. So the results and the benefits of ILFT aren't stagnant, and you continue to see them throughout, even COVID, and it's actually enabled that enhanced care during these very difficult times. So absolutely, and great points. And Dr. Dowd, to your point, having something, you don't know what you've got until it's gone.
Until it's gone.
Way to recognize the benefit, and also to provide that additional value does start to put the laboratory at the forefront of decision making and collaboration. So thank you both. And now I do actually see a question that's come in from the audience, and I think it's probably timely to ask this now. From Axel Khan, he's asked, has there been any scaling up from Tayside to other regions already? It would be good to understand if this has already been adopted elsewhere.
I can maybe come in on that. We've been working closely with two other partners in Scotland, in other regions of Scotland, who'd got, I would think, about 50 to 75% of the way through the testing to actually implement this when COVID hit. The biggest challenge for any laboratory who wants to do this is actually the IT aspects of it within the lab, and getting the programming correct and getting the testing of that programming completed. So they're picking up the pieces in that again, and one of those sites is fairly close to going live. We had partners working in England who've gone live with this. So yes, other places. There are IT limitations for other areas of Scotland, but we've been working in different methodologies using newer pieces of IT that were implemented across Scotland for COVID purposes that would actually allow other parts of Scotland that are not able to do this to send their samples here in Tayside. And the Scottish Government is backing full rollout of this. We're about to implement over the next 2 to 3 years a new national IT system for labs in Scotland. And we're fully expecting the programming to be in place in that new system so that all of the big centres are able to undertake this.
So to follow on from that, there is certainly significant interest in England. One system's already up and live and running in Cumbria. Birmingham and Warwickshire are looking at setting up their systems. It is the laboratory information management systems that are the key, and as there are multiple of these around the country, they each require individual programming, but as more of them are being done, then hopefully we'll be able to share more of that knowledge going forward to improve the rollout.
That's outstanding, and given what we've learned about ILFT and the impact that it's had on patient care, costs, and its utility during COVID and beyond, it's wonderful to hear that it's being rolled out, and evidently your work has been quite an inspiration to other teams looking to achieve something similar. So that's fantastic.
Could I come in with one more thing here? The actual methodology of ILFT, although people don't understand necessarily and Tayside the nitty-gritty of it, they understand the concepts of using the power of all the IT that's at our disposal, as well as the co-production aspects, so that it's now not uncommon we get other clinical teams coming to the lab and saying, could we do an ILFT thing for diabetes? Could we do an ILFT thing for this cardiac? So they do understand the power of this way of working, and that is understood, and they're keen to replicate that in other clinical areas.
Absolutely. And I think that's a very powerful outcome that is a bit immeasurable when you think about the benefits of something like ILFT, because that's, having your clinical colleagues come to you looking for your input, looking for that collaboration. That's kind of the holy grail, if you will, in terms of outcomes for really elevating the lab from a value-based perspective. So I think that's, one of those intangible, immeasurable benefits of something like this. And I suspect there'll be lots of, new innovative projects coming out from that groundwork. So that's outstanding. Now I'd like to ask Professor Federico Lega an additional question. When thinking about laboratories, medical diagnoses, and therapies are really the first things that come to mind. Health systems also look towards laboratories as models of efficiency and speed, of course. So from the lens of health management, do you envision a role for laboratories to be more strategically involved? We've heard this great example from Dr. Dow and Dr. Dillon, and how this has really started a cascade within their institution. So do you see that kind of strategic leadership role within health systems and health services for laboratories?
Thanks, Colleen. As I said in my introduction, at the end, I do see it. And the example, actually, the exceptional work done by John and Ellie really show the way through which labs can impact more than everything else, actually, at the moment. A little bit of diagnostics, actually, imaging, obviously, is changing. We're going to have artificial intelligence. But when we start doing what they did, and we really give a clear example of what means doing predictive medicine, actually, that changed the course of a pathology and completely reconfigure the way we treat a cohort of patients. I mean, this is incredible. So what I say is the fact that we don't have to stop and celebrate just that. I mean, we don't have just to celebrate that. I mean, this is actually part of their job. They're doing research. They're changing the way we deliver care. But what I want to stress the fact that lab physicians have a mentality, have a culture which is quite different from the rest of physicians, okay? Because they are often they often have to organize system, right? They often have to, the work they do on a daily basis is much more, rather say, system as a system perspective rather than what happening in the other clinical units often. So what I want to stress the fact that I do see the fact that I think lab physicians should step in and have a more important role in the governance of their health organization. I see in the future that, for instance, a medical department should be run by lab physicians rather than by an internist or a specialist. Very interesting things that we saw in the last year is the fact that when we put a geriatrist or an internal medical doctor to run a musculoskeletal or an orthopedics department, incredible things happen. So at the same things, I think lab physician could actually run a medical department or a surgery department and make a difference because they have that kind of perspective. So one thing is actually I want them to see to step in and scale up roles within their health organization. I think they have the right approach to be very effective managing the different third wars that usually we have in health organization. They can even be very good medical directors. for that reason. I mean, if they want to move to a next level. So I think that in terms of governance of their health organization, I think is one of the professions that I will actually push for to be more involved in that. On the other side, as I said before, I think also lab physicians should be more involved in any committee, in any steering groups, in anything that actually the health system are doing at the level of authorities. If you have authorities reconfiguring, reshaping the network through which is delivered healthcare, I think lab physicians should be present in that committee, in that steering, because actually the example we just had, I mean, they have the kind of understanding of how innovation can actually will change things over the next month, a year, so they can actually bring that perspective within the conversation that happen at the policy making level. So yes, the answer is definitely yes, I see that.
Thank you, Professor Lega. And I've heard a similar explanation of the view of the laboratory. They have kind of a helicopter view, if you will, in which they see a broad view of what's occurring in the health system, and that gives them a unique perspective to provide some of those insights. And I think that's exactly what we're hearing from Dr. Dow and Dr. Dillon here as they discuss the power and outcomes associated with their ILFT projects. So thank you. Dr. Dow, another question for you. Have you any lessons learned from your experiences with ILFT about integrating the laboratory department in its decision-making process for governing an organization?
Well, teamwork is paramount. Talk to your teams, be part of a close-knit team if you can, communicate controversially these days face-to-face as much as you can rather than electronically. That's hugely important. I think one of the reasons that we were successful is we managed to step away from what's been a very traditional thing in lab medicine about the siloed approach for the individual specialties. We never really met microbiology terribly much before. So the chances to actually work together and look at the project as a whole, take ownership for the project outcomes as a whole, so that people could step back from the specific ownership of certain tests. Because you will come across problems, you will come across things that will require thinking about the box, thinking different ways to deliver things. And one of the things we had to do, the virologists had to hand over certain of their tests to chemistry. Now, in a different world with wonderful IT, you maybe didn't have to do that, but to make this work, they had to do that. So they had to be up in our systems, they had to be seen as chemistry tests and log through the whole system as chemistry tests. But that's what it took to make the whole thing work. And it sounds like a little thing, but lots of places would find that rather challenging because there's still a sense of ownership. These are my tests. So this sense of working holistically as a group to deliver the project, the end result of the project, and it doesn't really matter where things are done as long as it contributes to the end, I think is very, very important to get away from the siloed working. That's one huge thing. And as far as in clinical governance in the whole organisation is, I think I tried to say earlier that yes, the lab certainly has a much higher profile than it had previously. And that's good. We're asked far, far more things than we were. We're involved at the planning stages of things now, which is better rather than being told, oh, there's a new clinic starting tomorrow, can you do this? So which was the traditional way before at the last minute. So now it has improved. It has improved. And I can only see this being to the better for the outcomes for patients and the organisation.
Thank you, Dr. Dow. And so it sounds like there's been substantial process changes, not just within the laboratory, but outside the laboratory as well. And so just thinking about Dr. Lega's previous comments about, opportunities for enhancing, the role of laboratory in decision-making and whatnot. Do you have a comment or thoughts on some of those points related to, where he sees the future of the laboratory in decision-making?
Well, first thing, please don't make me manage the surgeons here. That's a definite no-no. Have to turn that one down.
Yeah.
I think one of the things that's difficult for people who work in the lab setting most of the time is stepping out of the lab. You know, being exposed to far more places and processes. For some people, that's really quite difficult. But many of us recognise that the opportunity to work more closely with colleagues is the way forward. I don't think we're not really represented, certainly locally. I mean, we don't have laboratory staff running other disciplines here at the moment. I'm not saying it'll never happen, but it's certainly, there would be challenges. I think there are challenges for that. You know, Federica will have come across it where because we work in the lab, we're not thought of as proper doctors by many people. You don't understand because you don't work in the wards. I've been very lucky with the colleagues I've had, like John and the other gastroenterologists we work incredibly closely with. They don't look at us like that because they've learned the value of what we can offer. So yes, future management challenges, definitely. I do think we have things to offer. I think the rigid quality processes that we go through in the lab, that, you know, we have an inspection 4 times a year on our processes. This is a whole step beyond anything that happens in the clinical setting. You know, it gives a and the familiarity that we have with process control. I liked your term, the helicopter view, means I think we do have a lot to offer the organisation from a managerial point of view. We have a different way of looking at things, perhaps. Maybe John will disagree with me on that.
I wouldn't dare, but I think that thing about the quality of care, which, you know, from a clinician's point of view, has been in the past relatively arbitrary, and it was what the senior clinician's view of it should be, whereas we're now increasingly aware that doing all of the small things properly makes an incredible impact on the overall outcomes, but it's having that quality control issue throughout the whole of the process, which we're now starting to embrace on the clinical side, but we are taking baby steps compared to the way the labs are. And I think having that process more embedded and starting to get more drive behind it as to what the important things are, so that we can start to reduce healthcare variation and improve the quality of care to each individual. And that requires decision support tools, and so things like ILFT, which is effectively a decision support tool driven by the results, taking those blood tests that are coming to the wards, for instance, and using them to flag interventions that the clinician should be considering around their patients, could be another step forward. And so therefore there's more opportunities for some of those quality control processes to move into clinical practice.
Thank you both. And it sounds like there's so many opportunities, and as more opportunities present themselves, you know, it's a bit of a cascade in a very positive way. I do have to ask Dr. Dow, with the lab in particular taking on, you know, some of these additional tasks and some of these additional roles, which are all very positive, are there any concerns from a resource perspective from the laboratories side of things?
I think we need to be careful not to spread ourselves too thin, particularly when you get involved in management things outside the lab. It tends to be a bit all-consuming. It can suck you up and remove you from your home base, and you find you're maybe spending more time on that than on what you think of as your normal routine job. So being very, very careful not to get spread too thinly. And I think it's very important, actually, to keep doing the day job as much as possible at the same time. You need to keep doing, you know, from my point of view, the duty biochemist sessions, because that's what's keeping you in touch with what's happening clinically out there.
Absolutely. So a strong balance, of course. And so we've heard a lot about, I guess, this corridor conversation between both yourself, Dr. Dow, and Dr. Dillon. And so it's obviously clear that the collaboration, not just between the two of you, but the key team members associated with ILFT, has been paramount to achieving what's the ILFT and the outcomes that you've achieved. And so, Dr. Dillon, I'll direct this question to you, but Dr. Dow, please do feel free to jump in. Do you have any, advice or lessons learned for how health systems can effectively develop these multidisciplinary teams, perhaps building on some of your experience associated with ILFT?
So I think the enablers are the clinicians realizing they've got a problem, or the managers realizing they've got a problem, and that's either something about waiting times for outpatients or catastrophic presentations acutely that are preventable. So I think that's the first stage. That's the enabler. Having relationships with your colleagues that you can go and share, I've got a problem, rather than trying to always look as if you're in perfect control. Admitting that there is a difficulty and a problem is perhaps the first step, and that needs to be an internal step to start with. And you need to be working in a healthcare environment that is supportive of that confession. Often healthcare environments are, we're all brilliant and we sort of walk on the planks of our own self-consciousness about across the chasm of indecision, and so we believe in ourselves rather too much, rather than admitting that we've got a problem and how we can improve it. So having an environment in which you can share that we have a difficulty here, how could we do something different, is an important first step to making that happen. And having receptive colleagues who are happy to come up with ideas and to share brainstorming ideas as to what they should happen. I mean, it was when I was talking to Ellie about the problems we were having with late presentation of liver disease and our clinics being overwhelmed, it coincided with the upgrade within the lab, bringing that new technology on board that opened up more possibilities for automation, and it was that sort of happy synergy. And so I think whenever you get a new development, it's thinking about what else can it do above and beyond, and we tend to get stuck into our own tram lines about it, and it's thinking laterally. And it was that idea of dealing with the easy stuff, so echoing some of the things Ellie said previously about not spreading yourself too thin. This project, while it took a while to develop, now that it's running, the vast majority of patients that go through it, the outcomes are all automated. It just happens for those patients. It doesn't require input and thought, and it highlights those patients that require a bit more thought, which means that by the time they arrive in clinic, for me to see all the easy patients I can discharge, ILFT has already done it for me, and I'm left with all the difficult patients. So as a clinician, it's made my life more interesting and arguably more difficult. So there is that angle to it as well. Ellie, I don't know if you want to jump in.
I mean, I think John summarised very neatly the identifying the problem, what was the thing that you needed to tackle, and how we went about it, and the advice about how to repeat that. The only other addition I think I would make to that is the experience I've had more recently with another similar project. We also involved, it was again primary care based, but not quite so IT heavy as ILFT, but we involved patients in the early discussion as well. There was, I went along with some trepidation to a very big kind of open session where all the clinicians, all the staff involved with diabetes, and a whole load of patients were there. And what came out of that at the end were some wonderful ideas about how we were going to do some things very differently. And the thrust of that direction came from what the patients wanted. And it's maybe something that certainly in the laboratory, we don't have the direct contact with patients. So it's important to make sure where a project is that should require that, to make sure that it's there, because how, particularly as we move forward with all the new technology, making sure that the patient voice is heard and how these systems are going to be delivered is very important.
Outstanding. So thank you. I take away two kind of key points among many here, is that having a bit of a unified goal for an integrated team to really unify around is a key piece to finding success in these types of initiatives and actually seeing those outcomes, particularly, for some of these bigger, more cumbersome projects like ILFT, which it sounds like it took several years to get it to where it needs to be. Having that team everybody's dedicated and on board certainly is a key factor for ensuring you have that multidisciplinary engagement in the long term. And also making sure that you have the right stakeholders. In some cases, it sounds like the patients have some of those unique insights and views that can really drive innovation that may not have necessarily been there before. So I think those are outstanding key points to include here. Now, as we move through, I think we have time for one last panel discussion, and I'll direct this to everybody here to provide their insights. Professor Lega, I'll start with you. So with the changing context in mind, what are the current and possible future opportunities for active participation and inclusion of laboratories in clinical and organizational decision making? And I know you've touched on some of these points, but it's your opportunity to provide a few last comments in this area.
Thank you, Colleen. This is actually a tough question because it has about sort of defining or devising a strategy through which there's a sort of a hostile takeover of lab medicine over the rest of the system and health organization. I'm not talking about this, obviously, but my idea is the following one. I think we need, at the level of scientific society, consolidating of a strong narrative about the contribution the labs and laboratory medicine is giving and could give it more in the future. So I think that's the level of the scientific society and its role actually that it should play in generating this narrative within the system. Second, I think there must be also a little bit of a shift in the way the scientific environment of the lab medicine start to participate more actively to the debate of health policy and health organizational reconfiguration. As Ellie was saying, they're naturally close in their lab environments, and even in their scientific context, they often discuss things actually that start from the bottom of what they do or from the core activity. So what I'm just posing as a challenge is whether they can be more active in contributing from the perspective of the lab medicine and what they do in the transformation to the health policy discourse and to the strategy for reconfiguring our system. There are lessons there, and they can use this lesson to step in and participate in that conversation. And third, I would say they're doing a great job. The laboratories are already pushing it within their health organization to generate integrated practice units, multidisciplinary work, to be proactive and active within the clinical pathways, devising under the definition. So I would say they have to keep going on that area and making that as a measure of success of a lab. So what I would say, there's a matrix through which we can assess the success of a lab from a clinical perspective or from a more core perspective. But there's another measure of success that actually whoever is leading the lab could actually make his own or own, which is how much I can actually be a driver in the transformation of my system, how much I can impact on that. That's leaving a legacy behind the lab, which goes well beyond the even more very important clinical contribution that the labs are giving.
Thank you, Dr. Lega. And I'll move it over to you, Dr. Dillon. Any comments related to future opportunities for active participation and inclusion of the laboratory in both your clinical and organizational decision making?
I think any aspect of laboratory work where there is a trigger test that would normally cascade other tests, that thinking about automating those responses to improve so that nobody falls through the cracks. I mean, if you think of many conditions where there's this cascade of care with the person who has an early symptom or sign or test that could be the sign of something more serious underlying it all, if we make them do something else and make the healthcare provider that's involved with them do something else, there are two opportunities to lose the patient from the system so that they represent later and in problems. The more that we can use the technology within the labs to pack together those tests, to refine the diagnosis, to add an additional calculation or test, those are the opportunities. And that now is increasingly branching across a wide spectrum of medicine as we struggle with the consequences of diabetes, the metabolic syndromes, liver disease, and other problems as well. So all of those, thinking about that bigger cascade of care. So echoing some of the things Federico said at the first, where the lab is seen as a way of reducing costs, we're actually, by adding small additional costs, to lab tests up front, you can save huge additional costs down the line. And thinking of those sequences of tests, I'm standing outside the labs looking in, but that's the, rather than that sequence of visits and consultations with clinicians to do additional tests, sensibly packaging tests together that are triggered by an abnormal result improves the quality of care and reduces the chances of the cascade. So it's thinking of that approach.
Thank you, Dr. Dillon. And so it sounds like there's opportunities for the labs to be models of efficiency and insights beyond, of course, ILFT, but across many clinical aspects. And so, Dr. Dow, as our laboratory view, I will leave the last word to you in this area, as I suspect you have, many plans and opportunities to be that leader.
Yeah, I'm really excited about the future because I think the opportunity for us to be outward facing rather than inward facing the way that we have been in the past is there for us. I think certainly in Scotland, when we have our new national IT system, the whole thrust of which is to allow exactly the sort of work that John describes so that we can integrate automatically between all of the different laboratory specialties. At the moment, we can do it on a small scale with difficulty with ILFT, but this will allow us to deliver more for the patients and the clinicians across the more complex range of conditions that we're seeing now, just as John described. I think that's a very, very exciting future to be involved in as a laboratorian, being able to, have somebody tick a box for a problem, and then for the lab to take that and then deliver completely an answer, not just a test result.
Outstanding. And I completely agree, that shift to that outward facing versus inward facing and consultative view really is the wonderful future that the lab has to look forward to. So thank you all for your perspective in this area. Now, I would like to use these last 15 minutes that we have as a team to open up the floor to those who have any questions or comments from the audience, as I think this is a wonderful opportunity to gain insights from the different views. We have Dr. Lega, who has the health management view, Dr. Dow, who has the laboratory view, and Dr. Dillon, who has the clinical view. And so if there are any questions, I do invite you to share them now. We actually do already have some questions submitted by the audience. So I will start with this one, which is directed to you, Dr. Dow, and Dr. Dillon, related to ILFT. Ellie Bredvel is looking to understand what the ingredients are to start a project like ILFT. Any enablers, any barriers? We've of course talked about the value of that corridor conversation, etc. But if there are any other key enablers and barriers that you'd like to discuss, and even how you've come out from those barriers, I think that this team in particular would be very interested in understanding your perspective.
I think John described very beautifully, you start off with a problem that you want to address. There's a problem you have and you want to fix it. And you realize that the way of fixing it might be quite complicated and challenging, but you actually have a vision of fixing the problem. So that's the first thing, identify what your problem is, your clinical problem that you want to address. Barriers, the sorts of barriers that we had tended to be very logistical, either in sample sharing within the laboratory, but again, the team agreed, yes, we want this to work, we will do that. And the majority of the barriers we had were actually in relation to information technology, because in common with many other places, our IT systems within the lab are not exactly hot off the press. Our LIM system is great, or we couldn't have done ILFT, but it's 25 years old. And we had to put in a lot of workarounds in various layers of the IT within the lab to get around the fact it was designed for silo working, not working together. But if you stick at it and think laterally, you will find a way around those particular problems. And that was one of the reasons the project took a while to get off the ground, because we had to surmount the IT problems that existed. So barriers like that. There were also barriers, I would have to say, when we initially were applying for the grant. And I mean, John might remember this. We went through all the processes, the correct processes for grant application and sign off and support by the organisation for the clinical trial when we were ready to go with this. We were awarded the grant and ready to start. And then some of our more senior laboratory management, not the immediate labs, but the people that we would count at the next level who don't actually work in the labs, said, oh, we can't afford to do this. And instead of having an argument, we just pointed out that they were, having been funded, they were legally obliged by the government to continue, and we just ignored them, basically. We did it anyway, because we knew this would work. We were fairly certain this was going to be an improvement in what went before. So you need to know when you can ignore the naysayers.
But I think, to echo what Ellie's saying, it does require a champion. So having a good story, a good reason for doing the test makes it easier, because you can then bring people with you. But you need to have a series of champions who are going to drive it forward, because there will be obstructions and there will be plenty of people who think, yes, it's a good idea, but it's impossible. That will be the common health service response. We've done it that way for hundreds of years because it was the way to do it, and we couldn't possibly think of doing it. It won't be possible. And you need champions who will say, yes, we can do it. We can sort this out, and to keep moving forward. And it's being dogged about it. So the barriers are just the inertia of the systems often. And so there are ways around it, but it requires quite a lot of effort to keep pushing and pushing and pushing each step of the way and getting it through. But it's having a good idea is the big enabler. That's if you've got a good idea and you've got an idea of how you're going to solve the problem, that's the biggest push forward. And then people who are prepared to push that forward overcomes most of the barriers. And usually, as Ellie said, it was IT and just other people who thought, oh, I'm not sure what this is going to do to me. Is it going to make me work harder or something? And it's just taking them aside and persuading them. And ultimately, there are times when it's easier to ask for forgiveness than it is to ask for permission, and just to push on and make it happen. And if you show that it's working, that's, you win in the end. No one's going to blame you for that.
Outstanding. So it sounds like step one is have your unified goal. Step two is build your team around that goal, and then of course integrate that measurement piece so you can begin to really justify and show the value of what you pushed for and worked so hard as a team for.
And I think sharing it widely, because you suddenly find allies in places that you didn't think you would find any, and suddenly you find big support who've also perceived that there is a problem here and they want it fixed for another reason. And that's, so sharing what you're planning on doing can be very helpful. And that's how we built quite a large multidisciplinary team. And that has the advantage of when you're having those days where it feels all overwhelming, someone else can put their shoulder to the wheel and help push it forward a little.
Absolutely. And I think that's a key piece. And I thank you for bringing that up. The opportunity to share within your institution, even outside your institution, you do garner that support. And we've seen that from your discussions here today, and even how ILFT has taken legs and moved to other areas within the UK and what have you. So I think that's wonderful advice. And so my last question here for you, Dr. Lega, is likely, thinking about the audience that we have here, that many are health managers. What would be your advice for health managers who are looking to achieve or integrate a similar project into their care? How would you suggest that they engage the laboratory in strategic and daily governance for their daily decision-making and practice?
Well, two things, very simple. One, I would say if there are any, usually there is a health organization, an executive committee or a board or whatever. I think the lab physicians, whoever represented labs, should be sitting in that committee. So that's recognition. And even if what I would suggest is the following things. the governance model of any health organization usually is based on the hierarchical structure of the organization. So it might be that the director of the laboratory doesn't sit at the level to sit in the board or at the clinical board level of the organization. But there are three roles in my mind, which are the pharmacist, the lab physicians, and the the leader of the diagnostic area. They should sit in any case within any clinical board in a health organization, because they are the three key roles for doing clinical governance, because they are basically working to support clinical processes, and they have the system perspective, the process perspective. So I think they should be involved in any case. So this is one and it's something for which I could lobby for in any health organization, and explain why this could be useful. So together with the clinical head of divisions, departments, if there's not a specific place for lab, I will in any case include the lab physicians within that perspective, because it really is transversal to many of the processes and changes that need to be done in health organization. Second things, I would ask, if I be health manager, to my lab physicians, to my lab director, to draft together with me sort of a strategic document envisioning what is going to happen in the next 2 to 5 years, and use that as a basis for a conversation with the rest of the clinical board about what we should do given the transformation. I think the doctors in the lab and in the other area that I mentioned could be very good in helping the health manager to do what we call horizon scanning. Okay, seeing actually in anticipation what happened, and help them to devise changes that could actually take place on the shop floor of the clinical activities. This is it.
Thank you all for your wonderful perspective, insights, as well as anecdotes associated with your experience. It sounds like there's several key takeaways from this discussion, and I hope these are as clear to everybody here as they are to me. You know, it's really clearly important to recognize that the lab is not just a cost center, but an opportunity to partner with these laboratorians to create, you know, that value. And we've seen a wonderful example from Dr. Dillon and Dr. Dow, the ILFT program. And algorithm, and how it's really changed not just the way they approach hepatology care within their institution, but also the way that the lab is integrated into decision making throughout. And some of that key advice that they've been kind enough to share is really having that unified and common goal, and team champions who can really push forward those types of initiatives are key to driving success. And so from these discussions, I really take that there are substantial opportunities for the future, as well as right now, for the lab to strategically integrate with the clinical teams, the IT teams, the health managers, really to achieve that measurable success. And I think all of these key themes really pair nicely with the Innovance of Healthcare Excellence Award Program, which is something that we've alluded to as we've discussed both ILFT, and Dr. Lega has introduced the whole concept of this program. And so I'll take a few minutes to provide a little bit more information about this Healthcare Excellence Award, as I know that one of the key features that Dr. Dow and Dr. Dillon have highlighted is that amplification and discussion and sharing of best practices is a key feature to really seeing the success of projects like ILFT. And so, as I've mentioned, Dr. Dow and Dr. Dillon were recognized by the Innovance of Healthcare Excellence Award Program in 2019 for their brilliant ILFT project. And you can see from my slide here that they really do embody the core principles of the program, which is a global award that looks to both inspire and celebrate integrated clinical care teams who have achieved immeasurable benefits for their stakeholders, which include the patients, payers, clinicians, and health systems. And so there is an opportunity to truly amplify and celebrate these best practices, which is exactly what they did. And as well, there's an opportunity this year to do the same should you be interested. And so I hope I'm not having the same, there we go. I say this all to say, not only to send my praises to Dr. Dow and Dr. Dillon for the great work that they've achieved, but also to share this opportunity with those in the audience that the 2021 third cycle of the Unimonte Healthcare Excellence Award Program is actually open now and closes on November 15th. And so applications for integrated clinical care teams who have unified across the care continuum to achieve something, a measurable difference within their institution should certainly apply. And thinking about the key takeaways from today's session, I think they'll be very valuable for anybody both interested in this award and also just interested in integrating across the care continuum. And so with that, I will stop sharing my screen and I will say thank you so much to our speakers and thank you to our attendees for your wonderful participation and interest in the program. I would like to also inform the attendees that immediately after the end of this session, there will be about a 30-minute break and you are warmly invited to network with other attendees and check out the exhibition area. And so thank you again to Dr. Dow, Professor Lega, and Professor Dillon for your wonderful insights and your participation on today's panel. Thank you all.
Thank you. Goodbye.